All right, so now we're going to go ahead and talk about gastrointestinal system, referring to the diverticular disease. All right, so with the diverticular disease, okay, you have a diverticula, which is formed when the mucosa and the submucosal layers of the intestines, which is also known as the colon, right, because we're talking about the large intestines here, herniate through the muscular wall because of high interluminal pressure, low volume in the colon, or decreased strength in the colon wall. Okay, so these are the different things of how these things can occur, and pretty much what diverticular disease is pretty much a bulging within the large intestine. You have a fluid, not fluid, but a sac-like protrusion or bulging outside of the large intestinal wall. Okay, so that's pretty much what it is in a nutshell, and these are the reasons of how. Okay, so here are some terms to know, because I know with this disease process it can get a very confusing, right? Everything starts to sound all alike, the same, and you put them all in the same category. So I hope that this will kind of clear up the different terms, so that way you can see what they are on their own. Okay, so diverticula or diverticulum, okay, is a sac-like herniation of the lining of the bowel that extends through a defect in the muscle layer of the large intestine. So pretty much a protrusion, a bulging, right, of the large intestine. So you have your large intestine and you have like a little pouch on the outside, right? And here you have diverticulosis, okay? And losis is multiple diverticula, okay? So multiple of these sac-like. So just one of the pouches that bulges out from the large intestine is called a diverticula, right? And then you have multiple diverticulas within the intestines, right? Without symptoms of inflammation. So pretty much multiple diverticula is known as diverticulosis, okay? Now you have diverticulitis, okay? Anything with itis at the end is inflammation. So as you can see here, losis is without inflammation, diverticulitis is with inflammation, okay? So it's going to be a result of trapped food or bacteria, right, in the diverticulum or diverticula, right, resulting in inflammation, okay? And I'm going to go into how you can get food in those areas, and the bacteria is pretty much where the stool sits, right? And in those areas, you have growth of bacteria and things like that happens in those areas that's going to cause the inflammation, okay? And then last but not least, peritonitis. Now, of course, peritonitis is definitely different from the rest of these, right? Hence the word doesn't even have a D in it, right? But peritonitis is one important thing that you need to know, because that is the main complication that you want to prevent from this disorder, all right? And pretty much what it is an inflammation of the peritoneum, right? Because we have itis here, so inflammations of the peritoneum, right? Of the serous membrane lining the abdominal cavity and covering the viscera, right? So with this here is a life-threatening, and I put it in red because it is very important. It is a life-threatening condition. Why? Right? The patient ends up going septic, right? Going through sepsis, and usually requires surgery. All right? So with peritonitis, right? Remember, the body is very sterile, and anything that protrudes outside of the abdominal cavity is not really so much sterile, right? Because your stomach, whatever you eat, just kind of goes down into your stomach. Your large intestines, where you have the waste product, those areas are not as sterile, okay? So when those contents then protrude in outside of the abdominal cavity, where the rest of the body is sterile, right? I have a big risk of bacteria, of infection, and the body goes through septic shock. Okay, so it's a life-threatening condition, and this is what you're ultimately trying to prevent. Along with those three that I spoke about earlier, about the pressure, the decrease in the wall and the weakening of the wall, right? We also have another predisposing factor that can also cause why a person may have diverticular disease, okay? And one of it may be a low intake of dietary fiber. And you may say, what do fiber have to do anything with getting this disease? Well, remember, what can cause pressure, right? Because one of the main things of the causes was the pressure, right? The increase in pressure. Well, if I'm constipated or I'm not having an adequate amount of fiber within the body that kind of helps your body go to the bathroom, and you're straining to go, that puts pressure on the colons. And because it's put pressure on the colon, it can weaken those walls and cause the bulging or the sac-like pouches to form, okay? So that can be a predisposing factor of what can cause diverticular disease. Is pretty much a low intake of dietary fiber, okay? But the exact known cause of what causes it is not defined, okay? But we see through the pressure, the weakening of the walls, this is how it occurs. But why and what causes it, that exact information is not identified, okay? But here I did my best to draw the large intestines, and the large intestines are made up of 4 different parts. You have the ascending colon, you have the transverse colon, you have the descending colon, the sigmoid colon, finally the rectum, and then you have the anus, okay? But 4 major colons, okay? And the sigmoid is pretty much swiggled like almost like an S. So if you ever forget that part, just know sigmoid for S, that's the area where the colon looks like an S or swiggles, okay? So diverticulosis, the ileitis, the actual disease itself, occurs mainly on the left side, okay? Most commonly, it is going to be found on the left side in the region of the sigmoid area, all right? Now, for people who are Asian descent, there you may have it on the right side. They tend to have it more on the right side. So again, it's just probably a genetic factor or so, but I just want to let you guys know it can happen anywhere along the colon. I'm just letting you know the main common area is the left side. In Asian descent, it's going to be more on the right side. So if you get a question, they say the patient, came in their Asian descent or whatever the case may be, they're feeling pain, on the right side, or they're experiencing, diverticulosis or whatever, which side or whatever they may ask, just know it's the right side, okay, for the Asians. And here I did my best to draw the sac-like areas, okay, and I put them on this side as well. And in the green I have is the food particles, right? And then of course brown, because it's brown, right, is your stool, your poop, your waste product. So, of course, you're going to have waste product throughout the whole entire colon, but I'm just emphasizing mainly here. You have stool that can end up forming into the sac-like area here, and when you have the stool that ends up falling into the sac-like area, this is what's going to cause inflammation. Why? Because you have bacteria in the stool, and the bacteria is going to sit there. It is going to, try to live there, thrive there. And it gives off its own gases and different things like that, and its own waste product, which is going to cause irritation to the bowels itself and may cause inflammation. Okay, so this one sac is a diverticula, and remember, multiple sacs, right? I have 3 here, I drew 3 here, is diverticulosis, okay? So it's going to cause inflammation, right, and infection if continues, and eventually it's going to weaken the colonic wall of the diverticulum, okay? So if you hear diverticulum is the same thing, okay? And eventually what's going to happen is it's going to perforate, and when it perforates, it's going to increase irritability and spasticity, which is going to cause the diverticulitis, okay? So with this said, you're going to have inflammation here. Also with the food, because when the food sits here, right, it doesn't pass through, and mainly the food that kind of gets stuck here is your grains, your nuts. Those type of food get stuck in this region here, and that causes inflammation and pain to occur in that area. All right, and again here, I just wrote, this is almost similar, but just a different way of how it leads to the perforation, which is peritonitis. So this can eventually lead to an abscess. And once that abscess does occur, eventually it can sit or pool in that area. And what's going to happen is it's going to push more and more onto that large intestine wall. And when it does that, it perforates. And when it perforates, it erodes that protective layer, and now it goes into the outside of the abdominal cavity, which is going to cause peritonitis. There's going to be erosion of the arterial vessels, which eventually is going to cause bleeding. All right, which hence the word, when you go into septic shock, again, your blood pressure is going to drop. mainly because you are bleeding and your body is experiencing the shock of this infection. Okay, so a great big deal of inflammation. So now we're going to go into the clinical manifestations, right? Also known as your signs and symptoms, also known as your nursing assessment. All right, so we're going to have chronic constipation by many years. So eventually things like these happen over time. So again, if you're constantly constipated for many years, right, that puts a lot of pressure on the large intestines, which eventually those walls starts to give way, they become weak, and that's how you have the bulge sac. All right, you also have bowel irregularity, with intervals of diarrhea, nausea, and anorexia. Okay, so again, these are things that you're going to experience once you have this thing. Okay, so these are things that you want to watch out for. And how are you going to find out this information? Right? You want to be asking your patient, because you may not always be in the room when they have to go to the bathroom or when they feel constipated, because these are things that you cannot see. These are some things that you have to rely on the patient to tell you that, hey, I've been feeling, constipated, or, I'm having irregular bowels, at home, or things like that, right? So the only thing that you can observe is once they're in the hospital, if you're constantly seeing the diarrhea, if you're seeing the nausea, and then if they also are losing a lot of weight, okay, or they look slim, okay? So you have bloating is another thing, abdominal distension, right? The abdomen is going to be distended, right? You're going to have repeated local inflammation of the diverticula, okay? So within that area, like I was saying before, right, some people have it more on the left side than the right. If you're Asian descent, you may have it more on the right. So where you're going to feel the pain and the inflammation is in that local area. So you may feel pain or sharp pain in that side, okay, inflammation. So you may have large bowel narrowing with the fiber optic strictures. Okay, you have cramps, narrow stool, increased constipation. Like I said before, here you have the chronic constipation, which you will see eventually over some time, and then you have intestinal obstruction. All right, so all these are signs and symptoms that you can see in a patient who is going to have a diverticular disease. So what we have here is with diverticulitis, right? You know for a fact the inflammation is there, right? You have the constant inflammation. So you have an acute onset of mild to severe pain in the left lower quad. All right. Now again, of course, if we're dealing with Asian descent, it will be the right lower quad. But here is mainly going to be seen in your left lower quad. Okay, so LLQ stands for left lower quad. And here you may have vomiting, they may have a fever or chills, depending, especially if it's already perforated, right? And then leukocytosis, right? So your white blood cells are going to go up. You are going to have inflammation in that area because of wherever the inflammation is, or the infection, or the fact that it perforated and is now outside of the abdominal cavity, right? You're going to have the fever. You may have the chills. So these are the different signs and symptoms that you're going to have with diverticulitis, okay, when a person is actively having the diverticulitis. Then you have your diagnostic testing. So with your diagnostic testing, you have a colonoscopy, which is going to visualize the extent of the diverticular disease, right? And a doctor from there may go ahead and say, okay, I want to do a biopsy of the tissues to rule out for anything else, whether it's cancer, could be colon cancer, right? So you want to make sure that you're ruling out for those things. So you'll take a biopsy, which pretty much they pinch away at the tissue and collect some, and they'll put it under, take it to the lab or so, and from there they would look at the cells and see what's going on with the cells. Is it a cancerous cell? Is it regular? What's going on? Okay. The next thing you have is your barium enema, and your barium enema, right? Anything enema is going to go up the anus. Okay. So just in case you didn't know that, it is going to go up the anus area. Okay. And it's symptoms of peritoneal irritation, okay? It's contraindicated if the patient has the potential for perforation, okay? So pretty much what they're doing is same thing like when you have the barium swallow, right? The same barium solution that you have is pretty much going up as an enema. So like some people have like coffee enemas and things like that, or a regular saline flush, or water, right? Or water, tap water enema. Right? The same way how it's going to go up is the same thing with the barium. And the barium again is going to highlight the different areas, but remember it is contraindicated if they already have the potential for perforation, because remember the bowels, the large intestine is already inflamed. When this fluid goes up, right, it's just going to add more pressure. And if I already have something that has the potential to perforate, right, I want to have less pressure as possible. So again, it is contraindicated if they are actively having signs and symptoms of perforation. So this can be a question, right? When could they do a barium enema, or when is it contraindicated? Okay, so just remember that. Next you have is a CT with contrast. So W/ is pretty much with, all right? So you'll see a CT with contrast or without contrast. So this one is going to be with contrast because you want those areas to light up in the GI tract, okay? So it can also reveal an abscess, right? So remember, it's not only the bulging and the weakening of it, but it can be an abscess that's sitting in that sac-like area that's causing the pushing and the pressure of that large intestines, okay? Then you have your abdominal x-ray, and with your abdominal x-ray is going to demonstrate free air under the diaphragm if a perforation has occurred. All right, so the abdominal chest x-ray is just to kind of show safety measures, like, hey, is this person having a perforation right now? And it's going to let you know by the free air that you will see in the diaphragm area, okay? So if it has happened, you will see that. Okay, so now we're going to go on to the lab test. The lab test that they're going to check is your CBC, and CBC pretty much stands for complete blood count. And what you have in your CBC, you have white blood cells. I'm not too sure, but they may have ESR, which is elevated erythrocyte sedimentation rate, because I do know that they do have your white blood cells, red blood cells. They definitely have your platelet count, your hemoglobin, hematocrit. Those type of labs you're going to see in your CBC, okay? Then now you have your complications, right? So the things that you want to prevent. So you have peritonitis, which is the #1 thing that you want to try to prevent, okay? And with peritonitis, how do you know if a patient is having peritonitis or they're exhibiting signs and symptoms of? They're going to have abdominal pain. They're going to have a rigid board-like abdomen, okay? Rigid board-like abdomen. They're going to have a loss of bowel sound. So this is where your GI assessment comes in handy, right? And you'll sit there for 5 minutes and wait to hear if there's any bowel sounds. If there isn't, then you know that your bowel sounds are absent. And then last but not least, signs and symptoms of shock. Because again, they're going to go into septic shock. So signs and symptoms of shock, you're going to see the blood pressure is going to go down and the heart rate is going to try to compensate, so it's going to go up. So heart rate is going to go up, blood pressure is going to go down. Eventually, when the body's not able to compensate anymore, eventually you're going to see the heart rate starts to go down. And when you see heart rate going down, you better make sure you are doing everything you possibly can to keep a pulse. Otherwise, you are going to be doing CPR. That is going to be your next step, okay? So that is the major complication that you want to try to prevent, okay? Because it is life-threatening and death do occur, and it happens very fast. So you want to pay attention to the rigid board-like abdomen, all right? So abscess formation. So a complication that can occur is the abscess formation, which I spoke about before when I drew the illustration. I showed you in the bulge how you can have the abscess forming in that area. So abscess formation, what you're going to see, there's going to be tenderness. It may be a palpable mass, right? When you're palpating, remember when you're doing your GI and you're palpating, you may feel a little nodule, so you may feel like a little mass, right? And then you may see the patient have a fever, and then they may have leukocytosis, all right? Next thing is your fistula. And we're going to show a picture of what a fistula is. It will be, a picture is worth 1,000 words. So a fistula is pretty much a crack, okay? A crack within the large intestine, okay? And pretty much that sounds very painful. And with the fistulas, okay, that occur is because the wall is, again, it's weakened, right? And it starts to split. So you do see a crack, and that's going to increase the risk of inflammation, increase the risk of infection, right? There may be bleeding that does occur or happen, right? And then last but not least, again, you have as a complication is bleeding. And you have non-inflamed or slightly inflamed diverticula, right? It may erode areas adjacent to the arterial branches. So those areas, right, where you have arteries supplying blood flow to that organ, to those areas, right? All of a sudden now that weakening of the wall, that diverticula is eroding that area where the arteries are, those branches, and that's where the bleeding occurs. So that's why you're going to see the bleeding. So now we're going to go ahead and talk about the nurse interventions for a patient who has diverticular disease. So you want to have bed rest during the acute phase, right? You want the body to rest. When the body is able to rest, it is able to function and do what it has to do. Under a lot of stress, the body's not going to be able to cope or heal properly because it has to worry about doing other things. So when the body's able to rest, it increases the healing process, okay? Maintain NPO status or provide clear liquids during the acute phase, of course, as ordered. So most of the time, they may be NPO because their bowels is inflamed. You want to give them a chance to rest. So they may be NPO for a while, all right? From there, once the inflammation has started to decrease or the patient is not complaining of any pains or the signs and symptoms are ceasing, then they may go ahead and put on a diet, and they're going to start off slow with some liquid in the acute phase just to kind of make sure that, hey, you're not actively bleeding, we're not causing any more complication because you still have these things occurring, but we just want to give you something so in the meantime we can see how well your bowels is able to tolerate that, all right? Next thing you have is fiber-containing diet. You want to have that gradually, all right? So I underline that because you don't want it to happen right then and there, gradually, all right? When the inflammation has resolved. So once it has resolved, you want to gradually put fiber into their diet, okay? Next thing, you want to administer antibiotics, right? Antibiotics kind of run 7 to 10 days. You also have your analgesics, which is your pain medications, and you have anticholinergic, which is in this essence, it's used to reduce the bowel spasms. Okay, they can also use antispasmodic medications as well, and you want to refrain from lifting. You want to tell the patient, hey, don't worry about lifting or straining, coughing or bending, doing anything that's going to cause extra pressure or strain on the actual body. So if they need a sneeze or cough, you splint it with a pillow, right? You put the pillow there and they kind of hold on to the pillow so that way it kind of alleviates some of that pressure. So the main thing is restrain from straining, lifting, coughing, bending, any of those things because you want to avoid the intra-abdominal pressure. Next thing here is you want to monitor for perforation. You also want to monitor for hemorrhage, fistulas, and abscess. And we already went over the complications, and these are your complications. So you want to monitor to make sure that you're not causing those complications, okay? And we already remember the board-like abdomen, okay, is the main indicator. So you want to watch out for those things. Also, you want to increase the fluid intake to 2,500 to 3,000 mLs daily, all right? Unless the doctor said that it's contraindicated or, he gives you where he wants his range to be. But typically, it's 25 to 3,000 mLs, okay? Also, the client should eat a soft, high-fiber foods, right? Such as whole grain, okay? So those are your fibrous food, and you want to make sure that they're getting some of those things, okay? Now, put in here red, avoid high fiber. I know you're probably saying, but you just said, increase fiber. But you want to avoid high fiber foods, right, when the inflammation is occurring because it will only irritate the bowels more. Now, you're probably saying, okay, I'm getting confused here at this moment, all right? So, take a breather, all right? So, if I have a diverticular disease, and right in the large intestines, I have the area where the diverticulitis is now inflamed, right? I have those pockets of bacteria or the foods, the seeds, or whatever is in those pockets where the abscess is there. It's causing inflammation, right? I don't want this patient to be going to the bathroom as much because the more the patient goes to the bathroom, the more the bowels have to be used because that is the function of what the bowels are for. They are there to help facilitate the waste product. And one thing that fiber does what? It cannot be digested into the body, so eventually it has to come out, which facilitates the movement of you moving your bowels. So if I'm constantly on a high fiber diet and I'm in the active phase or the phase where my bowels are inflamed, and I'm there at that moment and I'm taking this high fiber diet, I'm just irritating those bowels even more, which eventually is going to increase the activity, right? Puts more pressure in that area, right, when the bowels are moving and going throughout, and that's what's going to cause the risk of the perforation and eventually lead to peritonitis or any of these other complications, the hemorrhage, the fistulas, right? So I don't want them to be on a high fiber. But once they are not in the active phase and they are doing a whole lot better and they just have the diverticulosis, right? I want to give them a high fiber diet because why? What is one of the main signs and symptoms of what these people are going to have? They're going to be constipated, and constipation causes what? Intra-abdominal pressure, right? Or at least pressure within the large intestine. And if those intestines are already weak and I have hard stool pushing through and you're straining, right? You're straining, what's going to happen? It's going to cause inflammation and irritation of that area, and eventually you're going to cause the very thing that you're trying to prevent. So when they are completely fine, they just have the diverticulosis, there is no inflammation, I want them to be on a high fiber diet because I want you to be able to go to the bathroom with no strain. I want your bowels to be able to flow and your stool and everything is able to be soft. That's what I want to see. But during the active phase, I do not want that because I do not want to irritate your bowels any more than what it already is going through. Does that make sense? I think so. A little bit better. All right? So here, again, you want to avoid, and I put it in red, and I put it big and bold because you are going to get questions about this. Okay? You want to avoid gas-forming foods and foods containing indigestible roughage, seeds, and nuts. Okay? These are the main thing, roughage, seeds, and nuts. You do not want to give this to a patient who has diverticulosis, period. Whether it's inflamed or not inflamed, you don't want to give them any of this because what happens, those foods don't get digested properly into the body. Same thing like corn. If you ever notice corn, it just comes out the way it went in. These type of food go back out the way they came in. So in those areas where they're in the small intestines, if I have pockets, those seeds or those roughage or those nuts fall into those pockets, which is eventually going to cause irritation of the bowels and is going to cause the inflammation. So again, you want to avoid giving this because ultimately when you do this, you avoid the inflammation problem from occurring. All right? Next thing, you want to consume small amounts of bran daily, or you want to take your bulk-forming laxative to increase the stool mass. All right? So I will go ahead and do another video about the bulk-forming laxative so that way you guys can kind of get a better idea of what kind of medications to look out for and to be aware of. And then you also want to make sure that you have an NG tube with suction, whether low intermittent suction, whatever the doctor wants or orders. And you will do this when you see that the patient is vomiting, whether the abdomen is very distended, and you want to do this because you want the bowels to rest. All right. The whole objective is you want the bowels to rest so that way it can kind of heal properly. All right. And then you have morphine is contraindicated, right? Because it increases intraluminal pressure in the colon. So they may not be prescribed morphine. They may have Percocet. They may have oxycodone, Dilaudid, but they try to avoid getting the morphine just because it gives that effect within the colon, and eventually if you have an increased pressure there, you have the risk for the inflammation, the perforation, the peritonitis. Okay, so you want to make sure you are doing everything that you possibly can to kind of prevent these infections, prevent this inflammation, prevent the complications from occurring. So now, last but not least, we have our surgical interventions. So again, you try to do surgery as a last resort. But in case of emergency, the patient comes in the bowels or they're already going to peritonitis or they're close to perforation, of course, again, you're going to go to some emergency situations where you may have to do surgery as a first thing because it has gone too far. But if we are in the beginning stages or so, again, you would do diet changes and medication modifications and things like that before you get to the actual surgery. But if and when it does occur, You're going to have a colon resection with a primary anastomosis, which may be an option, and then you have a temporary or permanent colostomy, which may require for increased bowel inflammation. Okay, so if you see that the patient is having increased bowel inflammation constantly, they may just go ahead and put a temporary or permanent colostomy bag, right? And temporary because sometimes you can have a temporary there while your bowels is actually healing, and then once they have fully healed, then they will go ahead and do a reversal, and they will put the large intestine back inside, and then from there they will continue the normal function. But if they see, it's too far gone, you're constantly having the inflammation, constantly, right? You have risk for the perforation or so, or your walls are just too weak, then you may have a permanent one, all right? So these are your surgical interventions that may occur with your patient who has to deal with this. Again, I want to thank you guys for watching. I hope this helped you understand diverticulitis disease a whole lot better. Again, if you like this video, please give it a thumbs up. Please subscribe. If you have any questions or comments, please put it in the comment section below. And again, thank you for coming on with me to this journey in nursing. Have a great, blessed day.